So a good day again. Welcome to part 2 of the board review in cardiology. So let's talk about ischemic heart disease, coronary artery disease, and atherosclerosis, starting with this multiple choice question. This is a review of your pathology. The initial lesion of atherosclerosis is, what is the answer? So that's the foam cell, right? So of course, the development of atherosclerosis is a chronic So the development of atherosclerosis is a chronic process that may start even at a young age, starting with the foam cells, later development of the fatty streak, then the atheromatous plaque, which develops into the complicated plaque that ruptures, that leads to your atherothrombotic event. So when you talk about atherothrombotic event, this is the event that occurs in the presence of pre-existing atherosclerosis, and it produces the following syndromes: your strokes, your ischemic strokes, your acute ischemic syndromes of the peripheral arteries, and of course, as far as the heart is concerned, your acute coronary syndrome, consisting of your unstable angina, myocardial infarction, your non-ST elevation, and ST elevation, myocardial infarction. So chest pain due to suspicious coronary artery disease may be secondary to an acute coronary syndrome, and the spectrum consists of your STEMI, your ST elevation MI, your non-ST elevation MI, and your unstable angina. Of course, the distinguishing factor between your MI and your angina is the elevation of your cardiac biomarkers for your myocardial infarction. Then you also have chronic chest pain, which is termed as chronic stable angina, in which the new nomenclature is now chronic coronary syndrome. These patients present with particular chest pain characterized as pressure, squeezing, or pain that occurs substernally, sometimes radiating to the jaw, the neck, the arms, shoulders, or even the back. There is also accompanying concomitant symptoms like nausea, diaphoresis, or feeling faint, and shortness of breath. These are called your anginal equivalents. So it's important to read on and review the following: the differences between the manifestations of stable angina, unstable angina, and your acute myocardial infarction. So let's start with a multiple choice question. So if chest pain or dyspnea occurs while doing ordinary physical activity, what is the functional classification? So when you have symptoms occurring during ordinary physical activity, this is a class 2 based on your NYHA functional classification. So try to remember when you say class 4, the symptoms so when you say class 4, you have symptoms that occur even at rest. Okay? And when you say class 1, you have patients that are able to do activities or ordinary physical activities, but you develop symptoms with extraordinary physical activity. There is a separate classification for angina, and that is the Canadian Cardiovascular Society classification, in which, similar to your NYHA, it's class 4 if you have angina on minimal exertion or even at rest, and you classify it as class 1 when you only develop angina with strenuous, rapid, or prolonged exertion. And in between would be your class 2 and your class 3. So the different spectrum among the cardiovascular causes of chest pain consists of your stable angina, in which you will have a retrosternal chest pain that radiates to or occasionally isolated to the neck, jaw, or other areas of the body, usually characterized as pressure, burning, squeezing, heaviness, less than 10 minutes duration, precipitated by exercise, cold weather, or stress, and it's usually relieved by rest or nitroglycerin. On physical examination, these patients may present with a normal examination findings. Unstable angina, on the other hand, will present with the same location, same quality, but this time more severe and frequent, usually less than 20 minutes duration. It has the same precipitating factor, but with decreasing tolerance for exertion or at rest. And there are same associated symptoms and signs, but may be pronounced. And finally, myocardial infarction. They present with substernal chest pain, which may radiate like angina. They may be characterized as heaviness, pressure, burning, constricting, and usually sudden onset, occurring for 30 minutes or longer, but this may be variable, and normally not relieved by rest or nitroglycerin, and accompanied by other symptoms like shortness of breath, sweating, weakness, nausea, vomiting. Physical examinations may be subtle, but they may present with a soft S1, a positive S3 if you have a patient with heart failure, a positive S4, or sometimes a holosystolic or a systolic murmur at the apex due to papillary muscle dysfunction. So stable angina in the new nomenclature are termed chronic coronary syndromes. And these are the chest pain that you see in patients who have stable ischemic heart disease, whilst unstable angina and myocardial infarction are your acute coronary syndromes. So when you say angina, you suspect anginal chest pain. But it's very important that clinically, based on the history, you look for risk factors of atherosclerosis and coronary artery disease. This will increase the chance that the cause of the chest pain is likely coronary or atherosclerosis. So when you talk about risk factors for atherosclerosis, you have your modifiable, consisting of the following: your smoking, obesity, physical inactivity, hypertension, diabetes, lipid disorders. And then you have your non-modifiable, of course, your age for a male, more than or equal to 45 years old, 55 years old for a female, of course, male gender or postmenopausal state, and genetics. So it's very important to remember the most common causes of chest pain. And these are the following that you will encounter in your clinical practice. Of course, the first one that you have to rule out is a coronary cause of chest pain, your acute coronary syndromes or your chronic coronary syndromes. A common cause would also be your esophageal or gastric reflux. And that's why a lot of patients who have gastroesophageal reflux disease go to the ER, sometimes presenting with chest pain, but they are not usually due to a coronary artery disease. Then you also have musculoskeletal chest pain. Usually the young patients with costochondritis can also present with chest pain. So the most common ones are the ones in bold print. So for angina pectoris, of course, you go back to your history. These patients present with modifiable and non-modifiable risk factors for atherosclerosis. There's a specific time of onset of the chest pain. It is usually related to effort, emotional, or psychosocial stress, and relieved with nitroglycerin. Musculoskeletal pain, of course, may present with a history of trauma. Usually this is vague and relieved with heat and anti-inflammatory drugs or pain relievers. And finally, your gastrointestinal cause, your gastroesophageal reflux. Patients usually can have history of indigestion, and this is related to food consumption. And it can be continuous for hours, not related to effort, and usually awakens the patient, sometimes in the middle of the night or early morning. And this particular pain is relieved with antacids. So when you talk about the most urgent cause of chest pain, it is the first three here that is printed in red. And in any patient presenting in the emergency room with chest pain, these are the top three that you have to rule out: an acute coronary syndrome, a dissecting aortic aneurysm, and pulmonary embolism. An aortic dissection can present with anterior chest pain, which may radiate to the back. A lot of times it can be an excruciating, tearing, or knife-like type of pain that is sudden in onset, unrelenting, and occurs in a setting of hypertension or some other predisposing factor such as Marfan syndrome in young patients. Of course, physical examination, you may have a murmur of aortic regurgitation. You may have discrepancies in your pulse or blood pressure measurement, and some patients may have neurologic deficit. Of course, the third urgent cause of chest pain is your pulmonary embolism. And characteristically, this can present with substernal chest pain. It can be pleuritic if there's involvement of a pulmonary infarction, or sometimes it can be angina-like. This is usually sudden onset, occurring for minutes to less than an hour, and may be aggravated by breathing, and usually accompanied by respiratory symptoms, especially dyspnea. In severe cases, you can have hypotension, signs of acute heart failure, and pulmonary hypertension. Of course, other physical examination findings, there may be rales, pleural rub, and usually this occurs in a setting of prolonged bed rest. So this is one of the things that you have to watch out for in your patients who are on prolonged bed rest with concomitant deep vein thrombosis of the legs. Other less common causes of chest pain are your pericarditis. This can also be substernal, but the characteristic feature here is it can be sharp, stabbing, knife-like, can last days, and it's aggravated by deep breathing, rotating the chest or supine position, and relieved by sitting up and leaning forward. That's one of the characteristic traits. And you can hear, sometimes you can hear a pericardial friction rub on physical examination. So just a summary of the causes of chest pain that can range from cardiac, vascular, pulmonary. Of course, the ones in red are the most urgent ones, consisting of your acute coronary syndrome, aortic dissection, pulmonary embolism. Other causes coming from the gastrointestinal tract, musculoskeletal system, as well as miscellaneous causes like emotional pain. The ones that are in bold print are the common ones. True or false? The following are clinical features of anginal pain brought on by physical or emotional exertion. That is true. Relieved by rest. That is a characteristic of anginal pain. Usually crushing, squeezing, or constricting in nature. Yes, that is a description of anginal chest pain. Is it retrosternal? That is true. Often worse after food or in cold winds. Yes, that is true. And relieved by nitrate. So all of the following are characteristics of anginal chest pain. This particular syndrome can also radiate to other parts of the body, like the jaw, the neck, usually the left shoulder and the left arm, sometimes in the periumbilical area. So let's go now to a multiple choice question. Which of the following factors will worsen angina? Is it an increase in heart rate, a decrease in contractility, an increase in myocardial oxygen supply, or decrease in vascular resistance of the coronary artery? So the answer here is letter A, an increase in heart rate. Because basically, angina involves an imbalance of the oxygen supply and the demand. When you talk about oxygen supply, these are the factors involved. Of course, your coronary blood flow, which is affected by your vascular resistance. Of course, your oxygen carrying capacity. Now, the factors that affect your demand include your heart rate, contractility, and the systolic wall tensions. The faster the heart rate, the higher the demand. The stronger the contractility or the systolic wall tension, the higher the demand, and so you can precipitate angina in this patient. Flashcard. The first diagnostic test to request in a patient presenting with anginal pain is, this should be easy for you, of course, it's a 12-lead ECG. Now, when dealing with this patient, you're dealing with a patient with angina, it's still important to go back to the cardiovascular risk factors, or your risk factors for atherosclerosis. Your modifiable and your non-modifiable, which means you're looking for clues that highly increase the probability that the cause of the chest pain is atherosclerosis, and you're dealing with coronary artery disease, because that's the most important and the most urgent condition that you need to rule out. Multiple choice. Which among the following promotes plaque instability? This is related to your pathology. So the answer here is thin layer of your fibrous cap. Okay? So remember, unstable plaque relates to the amount of the lipid core, the amount of inflammatory cells within the atheroma, as well as the thinness of the fibrous cap surrounding the particular atherosclerotic plaque. Okay, so plaque vulnerability is affected by a thin fibrous cap, a core size of the atheromatous plaque that's greater than 30%, an increase in macrophage, your inflammatory cells, would increase the probability of a plaque being vulnerable and rupture, inciting an atherothrombotic event. Of course, the degree of inflammation. So if you compare your patients who have a ruptured plaque and those with unstable plaque, normally these patients have a very thin fibrous cap and a thick lipid core with a lot of inflammatory cells. Multiple choice again. Primary mechanism involved in acute coronary syndrome is what? So the answer here is letter C, plaque rupture and resultant thrombus formation. All right? So acute coronary syndromes will present with ischemic discomfort. And this particular condition is divided into three spectrums. Okay? So patients who do not present with ST elevation may have either a non-ST elevation MI or unstable angina. Those who present with ST elevation, you're dealing with an ST elevation myocardial infarction. So an ST elevation MI is brought about by a platelet fibrin thrombus, okay? Mostly total occlusion of a particular coronary artery. On the other hand, your non-ST elevation MI and your unstable angina, this is caused by a platelet-rich thrombus, white thrombus, usually non-occlusive. Of course, the differentiating factor between your unstable angina and your MI, whether it's non-ST elevation MI or ST elevation MI, would be the presence of your biochemical markers. So the diagnosis of acute coronary syndrome consists of a good history of the characteristic chest pain, characteristic ECG changes, and the presence of biomarkers, most importantly your troponin. Okay? In the olden days, we also used to use CKMB, but now the recommended biomarker is your troponin. So when you talk about ST elevation MI, it means a significant elevation of the ST segment, as indicated in the arrow pointing to the J point. And these patients can present with pure ST segment elevation MI or a Q wave followed by an ST segment elevation MI. Right? And these are examples of 12-lead ECG of ST segment elevation MI. This particular patient, you can clearly see the angry ST elevation in the Q waves in V1, V2, V3, as well as V4, V5, corresponding to an anterior wall ST segment elevation MI. Now you also have some form of T-wave inversion in your lead 2-3 AVF, corresponding to reciprocal changes in your inferior wall. When you talk of non-ST segment elevation MI or unstable angina, they can present with either ST depression on your ECG, okay, depression of 1 millimeter or more in your J point, or a T-wave inversion on the right side. Okay? Sometimes they can present with a normal ECG. Okay? So these are examples of non-ST segment elevation MI. You can clearly see the T-wave inversion in your V1, V2, V3, V4, V5, V6, corresponding to ischemia in your anterolateral wall. And this is also seen in your lead 1 and your lead AVL. Flashcard. The gold standard biomarker for the diagnosis of acute MI is, I already mentioned this earlier, this is your troponin. All right? So your troponin is more specific and is the gold standard. You have two types, your troponin T and your troponin I. Right? Your troponin T lasts longer, about 10 to 14 days. Your troponin I is about 8 to 10 days. Okay? Now, importantly, not only is it a biomarker for diagnosis, it is also has a direct relationship with mortality. So this has prognostic implications. Okay? Now, it's very important to know that there are also conditions that can cause minor troponin elevations. Okay? Your heart failure, myocarditis, pulmonary embolism, and sometimes it can be falsely positively elevated, especially in patients who have renal failure, as well as other conditions like sepsis. Of course, you're important to get your extraction for your troponin in relation to the time course from the development of the chest pain. But your troponin starts to increase as early as 3 to 4 hours after the onset of chest pain, and it remains elevated from between 8 to 10 days to 10 to 14 days. Unlike your CKMB, which can also start to increase in 3 to 4 hours, but will decrease already after about 40 to 72 hours. Multiple choice. Which of the following would most likely suggest an acute myocardial infarction? Okay, I'll give you time to analyze the question. So you take a look at the biomarker, the findings on X-ray and ECG, as well as the CBC, right? So the correct answer here is what? Okay, so you look at the troponin. So it's letter C, an elevated troponin. Cardiomegaly by chest X-ray can suggest the presence of heart disease. Of course, you have significant ST segment elevation on your ECG, and leukocytosis can be seen in acute myocardial infarction because of the inflammatory nature of the infarct. So when you manage this patient, you have to triage them. A patient presenting with chest pain suggestive of ischemia, you have to do an initial 12-lead ECG on arrival at the ER. But of course, the goal is within 10 minutes, you're able to do all these all at the same time. Check the vital signs and oxygen saturation, establish an IV line, perform a brief targeted history, as well as a physical examination. And you look for contraindications to thrombolysis, especially when you're dealing with ST segment elevation MI, and you extract blood for your cardiac biomarkers. Of course, the initial treatment consists of your MONA. So you need to relieve pain, you give morphine or analgesics, you give oxygen if your O2 sat is less than 94%. Nitroglycerin can be given sublingual or intravenously if you have no contraindications to relieve the chest pain as well as to promote coronary perfusion. And you start the patient on aspirin, okay, 160 to 325 milligram. Then on your ECG, you're able to distinguish if you're dealing with an ST segment elevation MI, whether you have ST elevation in your ECG or a new or presumably new left bundle branch block. Or if you have other findings, you might be dealing with a high-risk unstable angina or a non-ST elevation MI, or a low-risk, intermediate-risk acute coronary syndrome. Now, general measures for acute coronary syndrome, these patients are admitted to the ICU or a monitored bed. Put the patient on bed rest and give supplemental oxygen if the SATs are less than 94%. Of course, the acronym to remember would be your RAPID. You relieve the chest pain, you give antithrombotic therapy, pharmacologic agents, intervention when needed, and finally, discharge instructions. Let's start with your letter A. Okay, to relieve chest pain, you give your morphine. Sometimes you can give nitrates if there are no contraindications. Antithrombotic, of course, your aspirin, clopidogrel. No? So dual antiplatelet therapy is the cornerstone in the management of acute coronary syndrome. In selected patients who will undergo intervention, other options might be your prasugrel. In a lot of these patients, you can give your heparin, okay, either unfractionated or your low molecular weight heparin. Pharmacologic agents consist of the following, okay, beta blockers, okay, nitrates. You need to start this patient on ACE inhibitor and ARBs, especially when you're dealing with a large anterior wall infarction. And regardless of the lipid profile, you need to start the patient on a statin to stabilize the plaque. And there are a lot of evidence that show that they improve outcomes, decrease mortality, and decrease the risk for reinfarction. Now, interventions are indicated in selected patients, as well as discharge instructions after you do all the other treatment measures. Okay? So what are parts of your pharmacologic therapy? Okay? You want to reduce myocardial oxygen demand. Okay? So the first-line therapy is to give beta blockers. Okay? You want to increase coronary blood flow and relieve the chest pain. This is what your nitrates will do. Just make sure you don't have a contraindication. And you want to prevent ventricular remodeling. Okay? The primary drug here is your ACE inhibitors. If you have a contraindication to ACE inhibitor or the patient cannot tolerate the ACE inhibitor, that's the only time you give your ARB. And of course, you want to stabilize the atherosclerotic plaque, and that's where your statins come in. Now, interventions, the important aspect, especially for ST elevation MI management, is timely reperfusion of the infarcted area. And this can be achieved either by fibrinolytic or percutaneous catheter intervention if you're in a facility with a cath lab. Let's go to a multiple choice question. True regarding the use of beta blockers in acute coronary syndrome. I'll give you a moment to read this. So what is the answer? So the answer here is letter B, right? Beta blockers, you want to improve myocardial supply and the demand mismatch by reducing the heart rate. All right? So in fact, beta blockers can also be protective against ventricular arrhythmia, but you cannot give them in patients who have advanced heart block. It improves ischemia, and it also has a role in the symptomatic relief of chest pain. So those are the advantages of your beta blocker. Right? So if you have contraindications, which are as follows, of course, bradycardic patients, hypotensive, those with severe heart failure and cardiogenic shock, and exacerbation of asthma or reactive airway disease, you cannot give your beta blockers. Right? So in the algorithm for ST segment elevation MI, okay, you target the time from onset of symptoms 12 hours, then you can achieve, you have to achieve the following reperfusion goals. No? Door to balloon time of 90 minutes if you're going to do PCI, or door to needle time goal of 30 minutes if you're going to do fibrinolytic therapy in these patients. Okay? So as far as fibrinolysis is concerned, just be familiar with the different fibrinolytic agents that you use. Okay? You have your streptokinase, your alteplase, your TPA. Okay? So these are preferred if your patient comes in early. Okay? The earlier the better. The target is, especially if it's 3 hours or less from the symptom onset and the delay to PCI. And if your PCI lab is not available and you expect some delay to invasive strategy. Okay? But important point to remember is this. Fibrinolytic is recommended only for ST segment elevation MI. It is not recommended in patients with unstable angina or non-ST segment elevation MI. All right? Okay, multiple choice. What is the definitive treatment of choice for ST segment elevation MI? This should be easy. Okay, the cornerstone is timely reperfusion using fibrinolytics or PCI. Next, which pharmacologic agent will improve the myocardial oxygen supply demand relationship, decrease pain, reduce infarct size, and decrease the incidence of serious ventricular arrhythmias among acute ST segment elevation MI patients? So this should be easy for you. This is a must know. We mentioned that earlier. These are your beta blockers, right? Next, in case index chest pain occurred more than 10 days, what cardiac enzyme would you request to verify if the patient had myocardial infarction? All right? So this is related to your knowledge of the time course for your serum cardiac biomarkers, right? The answer here is your troponin T. Multiple choice. The golden period for thrombolytic therapy in acute MI is, what do you think? So it's 12 hours, right? The earlier, the better. Okay, absolute contraindication to thrombolytic therapy. So the answer here is a history of cerebrovascular hemorrhage or intracranial hemorrhage. That is an absolute contraindication. The other ones listed are relative contraindication. What is the mechanism of anti-anginal effects of your nitrates? Systemic venodilation, dilation of epicardial coronary vessels, increased blood flow in collateral vessels. Well, the answer is actually all of the above. All right? Now, we mentioned about the transient apical systolic murmur in some patients with acute myocardial infarction. So what causes this apical systolic murmur? Is it the papillary muscle rupture? Is it the development of ventricular septal defect? Is it the free wall rupture? Or is it papillary muscle dysfunction? So the answer here is letter D. No? So this is papillary muscle dysfunction. Of course, the other causes listed in A, B, C can also present with murmur, but they are of a different type. A 74-year-old male consulted at the outpatient department because of chest heaviness, radiating to the left shoulder, noted after walking 2 blocks, relieved by rest. Okay, analyze the question. He has been having these episodes for the past 2 months. So what is the diagnosis? Okay, so based on the history, this patient has chronic stable angina. It's letter A, right? So in chronic stable angina, the management consists of interventions to improve outcome and to relieve symptoms. Okay, when you say improve outcome, as much as possible, you want to prevent mortality. No? You want to prolong survival in this patient. So the pharmacologic treatment involves aspirin or your antiplatelets, your ACE inhibitors. Statins should be given to these patients regardless of the lipid profile. And in selected patients who have severe coronary artery disease, the revascularization may be in place either by bypass or angioplasty. Of course, you need to relieve symptoms. You want to improve quality of life. You want to relieve the chest pain. And these are the pharmacologic treatment. Your beta blockers, calcium channel blockers, your nitrates. Second-line agents involve the following. No? Your trimetazidine, ranolazine, ivabradine, nicorandil, and your long-acting nitrates. Now, an important variant of your angina or chest pain is what we call a Sprins-Metals angina. This particular condition usually happens in young individuals. They present with severe chest pain spontaneously, and when they present to you in the ER, they present with ST segment elevation. Sometimes they present with arrhythmia or heart failure, but this particular condition is secondary to coronary artery spasm. such that when you give these patients nitrates or dihydropyridine calcium channel blockers, the ST segment reverts back to normal. Right? So the treatment for this Prince-Metals angina consists of either a calcium channel blocker, diltiazem, or the dihydropyridines, and your nitrates. So the tip for the PRC, as you grow older, you become wiser. No? Kaya bukas na lang kayo mag-aral. Of course, we do not develop this mentality. All right. Let's move on to heart failure. Okay, starting with this multiple choice question. The most common symptom of heart failure is what? Is it PND? Is it orthopnea? Is it dyspnea? Or is it nocturnal cough? So the most common symptom, and in fact, the primary symptom in your criteria is your dyspnea. Right? So in fact, when you say dyspnea, this refers to difficult or labored respiration or the unpleasant awareness of one's breathing. Defined in the ATS as a subjective experience of breathing discomfort, consists of qualitatively distinct sensations that vary in intensity. Okay? True or false? It may be an anginal equivalent. Yes, that is true. It exists. If it exists with chest pain, it suggests a large myocardial involvement in coronary artery disease. Is it true or false? Yes, that is true. It may be caused by anemia. That is true. Okay? Decrease in the oxygen carrying capacity of the blood does not occur in normal output heart failure. False. In fact, normal output heart failure also presents with dyspnea, and usually acute in pulmonary embolism. Yes, that's one of the characteristic form of dyspnea in pulmonary embolism. Right? So this one is from your books. When you talk about dyspnea, you're talking either of a cardiovascular cause or a respiratory cause. As far as cardiovascular cause is concerned, the primary etiology is basically due to heart failure. And you classify it into high output, normal output, or low output. The prototype low output heart failure is the one you see for congestive heart failure, and patients present with myocardial ischemia. Of course, in the normal output, these are the heart failure you see among patients who have diastolic dysfunction or left ventricular hypertrophy, or which we commonly term as your heart failure with preserved ejection fraction. And of course, you can also have dyspnea among patients who have high output heart failure, patients who have anemia, hyperthyroidism, and arteriovenous shunt, and several other conditions. Flashcard. In acute pulmonary edema, cough is associated with production of what character of sputum? Now, the characteristic sputum in acute pulmonary edema is a frothy pink sputum. All right? So the definition of heart failure is the abnormality of cardiac function that leads to the inability of the heart to pump blood to meet the body's basic metabolic demands, or when it can only do so with an elevated filling pressure. Okay? Now, there are a lot of direct causes of heart failure. Okay? It can be summarized into these groups. Okay? It can be due to a myocardial abnormality that can be caused by a problem in the blood vessel, which you see in coronary artery disease, patients with chronic ischemic heart disease, patients with myocardial infarction, or it can be a problem with the muscle, okay, which is seen in idiopathic dilated cardiomyopathy. Second, heart failure can be due to hemodynamic overload, and that's why this is what you will see in patients who have volume overload, in patients of renal failure. Okay. Number three, it can be due to ventricular filling abnormalities, and this is what you commonly see among hypertensive patients, among patients with valvular disease like mitral stenosis, aortic stenosis, and finally, changes in your cardiac rhythm, either tachycardia, bradycardia, irregular cardiac rhythm, can cause abnormalities in the filling of the heart, and this can lead to heart failure. Now, previously stable heart failure can easily go into a decompensated type of heart failure, and you have a lot of precipitating factors that can initiate such, right? Sometimes the patients forget their medications, or they take drugs that worsen the heart failure. Of course, arrhythmia, especially your atrial fibrillation, can precipitate an episode of heart failure. An episode of ischemia or infarction, okay, a new myocardial infarction or myocarditis can also precipitate heart failure. Some of the lifestyle factors, dietary indiscretions, a previous heart failure patient that takes a lot of water or increases salt intake can worsen previously stable heart failure. Of course, upregulation, conditions like pregnancy, hyperthyroidism, renal failure, okay? Worsening renal function can worsen your heart failure. Of course, your embolus, okay? Pulmonary embolism is a source of acute right-sided heart failure. And of course, finally, stenotic lesions like worsening of your aortic stenosis can further worsen your heart failure. Now, basically, if you want to simplify the pathophysiologic mechanism of heart failure, it all boils down to interplay of your neurohumoral mechanisms that are involved in the cardiac output and the blood pressure, in which your sympathetic, your angiotensin, aldosterone system, as well as your natriuretic peptide systems are involved, right? So, in summary, the neurohumoral interplay is an interplay between your sympathetic, your RAA system, renin-angiotensin-aldosterone system, factors related to volume such as your preload, your blood pressure, which is your vascular resistance, which contributes to your afterload. Now, this is very important to know the basic pathophysiologic mechanism, because knowing so, you will know what treatment to give, okay? For your sympathetic factor, that's where your beta blockers will come in. Of course, the neurohumoral mechanism involving your renin-angiotensin-aldosterone, and that's why ACE inhibitors and aldosterone antagonists are part of the armamentarium in the treatment of this patient. Of course, volume, you need to give your diuretics. And finally, in a lot of these patients, you want to control the blood pressure, your peripheral vascular resistance, to control the afterload, and this is why you give vasodilators to this patient. Now, a fifth factor here, of course, especially in patients who have low output heart failure, okay, reduced ejection fraction, is your contractility. And this is where your inotropic agents, okay, agents that try to increase cardiac contractility, will come in. Let's go now to a multiple choice question. Which among the following is a major criteria for the diagnosis of heart failure? Now, this is very important to know your Framingham criteria. So the answer here is letter D, right? Your S3 gallop. Okay, so your S3 gallop is part of your major criteria for congestive heart failure, along with others like PND or orthopnea, distension of the neck veins, the presence of crackles, cardiomegaly, acute pulmonary edema, an elevated JVP or hepatojugular reflux, right? Of course, minor criteria consists of the following. Okay, so the presence of two major or one major plus two minor criteria constitutes the diagnosis of congestive heart failure. So which statement correctly describes paroxysmal nocturnal dyspnea? So the answer here is, this is dyspnea due to interstitial pulmonary edema and sometimes intra-alveolar edema. Right? We'll discuss that later. Okay. What is true regarding orthopnea? Is this dyspnea that occurs in the upright or standing position, relieved by recumbent position? Or is it due to increase in hydrostatic pressure in the lungs that occurs with assumption of the supine position? Is it exclusive for heart failure? Or is it an earlier manifestation of heart failure than exertional dyspnea? So the answer here is letter B. No? So it is due to increase in hydrostatic pressure in the lungs that occurs with assumption of the supine position. So you need to differentiate orthopnea from paroxysmal nocturnal dyspnea. When you say orthopnea, Your dyspnea occurs in the recumbent position with relief by sitting or upright or standing. So there's immediate dyspnea when you go to the recumbent position, and it gets relieved by sitting upright or standing. And this is due to an increase in hydrostatic pressure in the lungs. So much so that patients with orthopnea, they increase the number of pillows in their back in order to achieve relief of the dyspnea. And this is due to pulmonary venous hypertension and heart failure, and is a later manifestation than exertional dyspnea. On the other hand, PND, or paroxysmal nocturnal dyspnea, you have acute episodes of severe dyspnea, sometimes also with coughing, occurring during sleep. Commonly, it happens 2 to 3 hours after going to sleep in the supine position, and you get relieved by assuming the upright position, usually not immediately, after about 10 to 20 minutes getting out of bed or sitting on the side of the bed. And usually it does not recur after the patient goes back to sleep. Sometimes can be associated with sweating, cough, wheezing. Okay? And this is a classic sign of interstitial pulmonary edema due to heart failure or left ventricular failure. Which one of the following serologic tests would be the most helpful for detecting left ventricular dysfunction and is a marker for heart failure? All right? So the answer here is your B natriuretic peptide, or your BNP. No? So this is a diagnostic and a prognostic marker for heart failure. But of course, among the different clinical markers or clinical features for heart failure, usually it's the ejection fraction that correlates with a higher mortality, as proven by a lot of studies. And the lower the ejection fraction, the higher the mortality of the patient. Okay? And the ejection fraction is also one of the defining clinical parameters for you to divide the classification of your heart failure into systolic versus diastolic. Okay? Then you also have other forms of classification like low output versus high output, or left-sided versus right-sided. Right? So systolic versus diastolic is actually an old concept. No? In the olden days, we defined systolic failure characterized by hearts who have thin walls and signs of systolic failure, which means decreased contractility and with a reduced ejection fraction. This usually happens in patients with coronary artery disease, a previous myocardial infarct, and due to ischemia-induced decrease in contractility. On the other hand, diastolic dysfunction are characterized by thick heart walls that leads to diastolic heart failure, or a failure abnormality in left ventricular filling. In this particular condition, the ejection fraction is normal or increased. This happens in hypertensive patients, and it is due to chronic replacement fibrosis and ischemia-induced increase in distensibility. Most commonly, in most patients, it's a combination of both. And the current concept really is, instead of classifying it into systolic versus diastolic heart failure, we classify it into HFrEF, or heart failure with reduced ejection fraction, which is an ejection fraction of less than 40%, versus HFpEF, heart failure with preserved ejection fraction, which you have a normal EF, or an increased EF. Okay? There's a separate classification, the mid-reduced ejection fraction, which is an EF between 40 to 50%. So that's your HFrEF and your HFpEF. Now, low output versus high output, exemplified by the following. Of course, high output heart failure, you see that in severely anemic patients, those who have AV malformations, hyperthyroid conditions, while low cardiac output is the one you see in a typical prototype heart failure seen in coronary artery disease and dilated cardiomyopathy. And finally, differentiating your right versus left-sided heart failure. All right, so when you have right-sided heart failure, it's characterized by clinical manifestations of peripheral edema, congestive hepatosplenomegaly, systemic venous distension. Left heart failure presents with pulmonary congestion, secondary to an elevated left atrial pressure and pulmonary capillary wedge pressure. And this is due to a hemodynamic overload or a weakened left ventricle. Then you can also have biventricular failure among patients usually with a dilated cardiomyopathy. This is a typical patient with left-sided heart failure. They present with dyspnea, they present with PND and orthopnea. Okay, and on X-ray you see pulmonary congestion, cephalization, or sometimes acute pulmonary edema. Of course, remember the conditions that lead to left-sided heart failure. Any pathology in the left ventricle, such as your valvular heart disease, your myocardial infarction, your idiopathic dilated cardiomyopathy, your coronary artery disease, as well as your hypertension. Right-sided heart failure refers to failure of the right ventricle, and that's why these patients present with edema, hepatomegaly, splenomegaly, ascites. Okay, and on X-ray you have typical findings of right atrial dilatation, right ventricular hypertrophy, and sometimes pulmonary hypertension. And of course, the conditions that lead to right-sided heart failure are the following. No? So valvular disease like your mitral stenosis, as well as other particular conditions. So when we treat heart failure, you have two objectives. You want to improve morbidity. That's why you want to relieve dyspnea. You want to relieve symptoms. You want to improve quality of life. You want to increase their exercise capacity. And number two, you want to improve mortality, no? Prolong survival, okay? Prevent death. Okay? You want to decrease progression of heart failure. You want to prevent sudden death. Okay? Now, this can be achieved first, non-pharmacological management. Of course, this consists of course, limitation of the fluids or restriction of sodium. Risk factor management is very important, especially for patients who have risk factors of coronary artery disease. Exercise cardiac rehabilitation has been proven to also improve outcomes among this patient. And in a lot of times, a multidisciplinary disease management approach is very important. Now, there are certain disease-specific management that may be involved. For patients with valve abnormalities, surgical intervention, correction of the valve, or congenital heart disease is vital in order to correct the cause of the heart failure. Now, when we talk about pharmacological management, okay, you have a lot of drugs, and that's why, similar to your acronym for your hypertension, we start with the first 5 letters of the alphabet. Now, of course, in this particular condition, your C stands for congestive heart failure, and so you cross that one out, right? So you're now left with A, B, D, and E. And so A stands for your ACE inhibitors, or ARBs, okay? This is part of your armamentarium for heart failure. B stands for beta blockers. D is for diuretics, for the symptoms of heart failure. And of course, E is what? Yes, etc. These are your other drugs, your dilators consisting of your nitrates, your digitalis, dobutamine, sympathomimetics. So I crossed out the C because C, which stands for calcium channel blockers, are contraindicated in heart failure. So always remember that, all right? So now there are several other novel drugs that have been proven to improve outcomes in this patient. These are your ARNIs, your angiotensin receptor neprilysin inhibitors. This is your sacubitril valsartan. This is already included in your books. There are also pure heart rate lowering agents, your ivabradine, also part of your new armamentarium for heart failure with reduced ejection fraction, right? So in the principles of pharmacologic management, we mentioned that you target the pathophysiology, which is the neurohumoral activity. You want to decrease the neurohumoral activity involved in heart failure. You want to decrease preload. You want to decrease afterload. And in some patients, you want to increase inotropy, increase contractility of the heart. How are you able to achieve that? So you're able to achieve that with ACE inhibitors and beta blockers. Take note that first line should be ACE inhibitors. You only give an ARB if you have a contraindication to ACE inhibitors, or your patient cannot tolerate your ACE inhibitors. Okay? To decrease preload, you can give your diuretics. This is where your loop diuretics like furosemide comes in. Of course, other options are your thiazides, your spironolactone. And then you have your dilators, your nitrates, right, to decrease preload. Then for the afterload, you also give your ACE inhibitors, ARBs, and hydralazine in selected patients. And among patients who have reduced ejection fraction, digitalis can also be given to decrease hospitalization, improve symptoms, as well as other drugs in selected patients like your dobutamine and other sympathomimetics. But take note, the cornerstone of the pharmacologic treatment of heart failure remain to be your ACE inhibitors, ARBs, and your beta blockers. And in selected patients, sometimes your ARNIs, sacubitril valsartan. Okay, and the new agents will also include your ivabradine, your heart rate reduction agents. Multiple choice. So which of the following heart failure treatments improves survival? This should be easy. So among the different agents, pharmacologic agents for heart failure, it is only the one that targets the neurohumoral mechanism, your renin-angiotensin system, and your adrenergic system that improves survival. So the answer here is your captopril, which is an ACE inhibitor. Furosemide improves symptoms, but has not been shown to improve survival, similar to nitrates. Digoxin also improves symptoms, decreases hospitalization, but has not been shown to improve mortality. Which is true regarding the effects of ACE inhibitors? What is the answer here? So the answer is letter D. Your ACE inhibitors improves both symptoms and survival, right? So that's why they are part of the primary pharmacologic treatment in heart failure. Which one of the following is considered a contraindication to the use of beta blockers for congestive heart failure? So the answer here is letter B, symptomatic heart block, right? Take note that mild asthma is not a contraindication. So are class 3 heart failure or an ejection fraction of less than 30%. But you cannot give beta blockers to those who have symptomatic heart block. So beta blockers, contraindications are asthma in exacerbation or reactive airway disease, AV block, symptomatic hypotension, bradycardia, and diabetes is not a contraindication. Now, this one is very important. What beta blockers have demonstrated improved survival among heart failure patients? So take note that not all beta blockers are created equal. And there are only 4 beta blockers demonstrated based on scientific studies to improve survival among heart failure patients. They are metoprolol succinate. You have to specify the succinate salt, not the tartrate. You have bisoprolol. You have carvedilol. You have nebivolol. So there are particular trials proving that these beta blockers improve survival in heart failure. Now, talking about diuretics, of course, we give diuretics to control symptoms secondary to fluid retention. Okay, but there is no evidence it improves survival, except for one. What is that? What potassium-sparing diuretic has been shown to improve survival among heart failure patients? So the answer is spironolactone. So this is the diuretic based on the Rouse trial shown to improve survival. Although in reality, the dose you give is not the diuretic dose. It's a dose to just block the aldosterone mechanism. So it's acting as an aldosterone antagonist. Flashcard. Digitalis improves cardiac contractility by blocking what channel? This is a review of your pharmacology. The answer is sodium-potassium ATPase channel. Okay, by blocking the sodium-potassium ATPase channel, you increase influx of calcium through your sodium-calcium exchange, and that will increase contractility. Multiple choice. The concomitant use of spironolactone and an ACE inhibitor in a patient with chronic renal failure may result in elevation of what ion? All right, the answer is letter A. Okay, so that's why, as much as possible, you have to be very careful, or you have to avoid a combination of spironolactone and ACE inhibitor, especially in patients who have renal dysfunction, because this can further increase your potassium and you can have catastrophic consequences. Which of the following is a clinical effect of ACE inhibitors? Do they increase LV remodeling, reduce LV remodeling, both or neither? All right, so the answer is letter A. All right, so ACE inhibitors increases LV remodeling. All right. Okay, so which of the following is a clinical effect of ACE inhibitors? Is it A, increases left ventricular remodeling, B, reduces left ventricular remodeling? Is it both or neither? Okay, I think you already saw the answer. The answer is letter B. Okay, so it reduces left ventricular remodeling. One of the following side effects prohibits further use of your ACE inhibitors. Letter A, hypotension, B, worsening renal function, C, angioedema, or D, cough. So the side effects that prevents further use is your angioedema. All right? So letter A, B, and C does not necessitate you to discontinue your ACE inhibitors. Right? Okay. The following prevents degradation of bradykinin, leading to decreased vasodilation. Is it letter A, enalapril, B, losartan, C, clonidine, D, nitroglycerin? So the answer is your enalapril. In fact, the prevention of degradation of bradykinin in your ACE inhibitor is the one that's responsible for the cough, right? But it also has beneficial effects like increased vasodilation, which is very important among patients who have heart failure. All right, so this is the end of part 2. I'll see you in a bit.